Yes. So good evening or good afternoon, everyone. And it's my name is Abdullah Ali. I'm the consultant geriatrician in Zayed Military Hospital in United Arab Emirates. It's give me great pleasure to welcome you all to the fourth Abu Dhabi Geriatric Medicine and Senior Citizen virtual edition of the conference. First of all, I want to thank the MCO company for starting this initiative together. And over the last 4 years, we are holding this conference. Actually, this conference supposed to be held earlier this year in April, but as you know, because of the pandemic, this has been postponed. And the pandemic have advantages and disadvantages, and one of the advantages is push everyone and to use technology. As every year, we are holding this conference. We're trying to increase awareness of geriatric medicine and improve the care of elderly patients among different healthcare workers. That's why when we select the topics, we try to make sure that they meet the expectation of all the healthcare providers from different specialties. I want to thank the speakers who agreed to join us this year and to share also their expertise with us. Today, initially we're supposed to have 8 topics, but unfortunately one of the speakers will not be able to join us. So today we will finish earlier, inshallah. Today scientific evening will be divided in 2 sessions. The first session is going to be 4 topics, and then we're going to have question and answers, and then we have a short break. Then we're going to move to the second session, which can contain three topics, and then question and answer. Then we're going to close this scientific meeting. I hope you enjoy our event today, and inshallah hopefully it's going to be light and useful conference, and everyone will go home inshallah and with taking home messages inshallah. So I want to start the first session with Dr. Ali Al-Amir. He's a geriatrician from Saudi Arabia. Dr. Ali Al-Amir, he finished his training in geriatric medicine from Sweden, and currently now he's working in Saudi Arabia, and he's director of the home care there. Dr. Ali, I know him from Twitter, and this is the first time to meet him and listen to his voice. So Dr. Ali, we're going to talk to us about palliative care for patients with dementia. Dr. Ali, go ahead.
Assalamu alaikum. Thank you, thank you, Dr. Abdullah, for your introduction. And it's my honor to be with you online. And I hope next year to join you there in Abu Dhabi. Do you see me clear and hear me? Yes. My name is Ali Al-Amir, specialist in geriatric medicine, working in home health care in Dammam Medical Complex in Saudi Arabia, Eastern region. I'll cover these subjects during my presentation: palliative care principle, clinical sign of severe dementia, and advanced care planning is the key, clinical challenges and solution, pharmacological symptom relief at the end of life. I would like to highlight most of my reference were literature review, interesting studies. As you know, this palliative area, when it's come to advanced dementia, we don't have a well-established guideline, and I will share with you my reference. First, I would like to highlight in palliative care, and when it will come to dementia, medication alone will not solve all the problem. Smart physician or medical staff alone without a teamwork will not also solve the problem. It's different in geriatric medicine. Why do we need to have about or to talk about palliative care and dementia? As you see here, aging population is increasing. By 2030, we will be around 10% of our population here in Saudi above 60 years old. So to have a patient with dementia, it's not only in geriatric OPD. You will have, you are going to meet them in the primary care, on the orthopedic department. This is one of the reasons. I asked myself, what are we doing? How good are we in palliative care when it comes to patient with dementia? This interesting study from Swedish Palliative Register published 2018. During 2012 to 2015, data from 66% of all deaths in Sweden were gathered with a web-based end-of-life questionnaire, which is completed by healthcare staff after the death of patient. Of the 13 of end-of-life care quality indicator exam, 6 showed worse end-of-life care outcome for patient dying from dementia when compared to patient dying with cancer. So in this study, where around 50,000 patients with dementia, around 16,000 patients with dementia, they compare the quality of care they get at the end of the life. There were not optimal when it comes to patient with with dementia. They get less palliative care consultation, receiving information about transition to end-of-life care to the caregiver were less for caregiver for patient with dementia. Prescribing BRN drugs for against anxiety and nausea were less in patient with dementia. Dementia leads to death. According to different literature review, no cure, symptomatic treatment, most of what we are doing, at least 2.5 times higher mortality rate in patients with dementia comparing to other patients who doesn't have a dementia. Cause of death in dementia, pneumonia and ischemic heart disease. There could be a difference between vascular dementia, Alzheimer dementia, vascular, maybe they die because of ischemic heart disease. But in general, this is the main causes of death. What to expect? The question what we can expect is central, not only for us as a doctor, but also for patient and caregiver. We make our treatment plan based on what appropriate different stage of the disease. For example, decision about antibiotic in Alzheimer patient is still living at home compared to person same with Alzheimer dementia, but in terminal stage of the disease would be different. As you can see here in this, here in y-axis, the functional level, X here, the time. In cancer, here in the black color, you will have period of slow progression and then quite fast decline in functional decline during the last palliative phase. The red color, heart failure, COPD, you can see slow progress on long period with mix of short episode or period of severe critical episode. In dementia, you will have prolonged disease progression on many years, and we will see fluctuation in functional level. A question here. I will share a question. Predictor of dementia progression. Is it many mental test, MOCA test, MRI, rate of progression the year before? I'll share the 4 seconds remaining. Okay. This is the result that we get. I'll answer the question during the coming slide. Palliative care is not a few days, and dementia is contained of 4 phases. Here, mild cognitive impairment. Here we have only a memory problem, but it will not affect the functional level of the patient. In mild phase of dementia, the memory or cognitive decline will affect the functional life of the patient, especially when it will come to instrumental activity daily living. For example, preparing food, taking care of financial issue. When it comes to moderate phase of dementia, the patient will need help with the basic daily life activity, like going to toilet, changing clothes, and these things. And then severe dementia, the patient is dependent on other. And the specific sign here in this stage is dysphagia, recurrent infection, bedbound, and communication problem. The disease course, as you see in dementia, will progress during anything between 5 to 20 years if nothing acute happens. The rate will be quite constant. In fact, the best predictor seems to be the rate of progression the year before. Because of prolonged disease course and fluctuation, it could be difficult to know if the patient is nearing the end life stage. So in this stage, severe dementia, patient could stay alive for a few weeks, month, maybe a year. So it would be difficult for us to decide exactly how long is the patient going to be alive. But this the classification will help us as a medical staff to have a plan of care. And the coming slide, we will focus in this area, severe dementia, the last few days of the patient life, and the long advanced dementia period, which is going to be maybe a few weeks, month, or a year. Survival time after diagnosis. So as I said, if we would like to have the rate of progression the year before in real life in the clinic, how could I do this? You could use the mild cognitive impairment and this classification, or there is other methods like functional assessment staging, like it's from 1 to 7, let's say 6B, moderate severe dementia, the patient need help with bathing. So you can document it and evaluate it each year. Other methods, they use it mostly, or it's most common on nursing home. It's indicate advanced dementia prognostic tool to predict the mortality risk between the 6 months in nursing home. So these methods could help us to see in which stage is the patient. World Health Organization has a definition of palliative care. Here, I would like to highlight that 40 million persons in the world, they need palliative care every year. What do we mean about palliative care? It's a comprehensive approach that focuses on relieving and prevented symptoms that caused by the disease. It's appropriate in all stages of the disease, but of course, it's most important in the terminal phase. Palliative care has the goal to address all physical, emotional, spiritual, and psychosocial concerns that may arise. Palliative care focuses on the quality of life. Palliative care, it consists of 4 cornerstones, if we could say like this. Symptom control and prevention, because if we were able to keep the symptom away from the specific disease, people can focus in life instead of focusing in the disease. Teamwork, what do we mean about teamwork? It's not an emotional word here. You need to have a good leadership, Each member of the team know what's his or her task. You need to have a clear aim and plan of care. Communication and early care planning, I will come to it in details in a few slides. Caregiver support, it means you give them clear you have or you provide to them an easy contact with the it doesn't need to be with you, with the doctor directly or the medical staff, but they need to have a contact if they need it. Communication checklist for dialogue with the family when it comes to communication. It should cover the course of the illness for related person, describe sign of end stage of dementia, uh, continually describe for them where the dementia, in which stage is the patient, speak in advance about nutrition and fluid at the end of life, describe common cause of death. Also, maybe you need to share with them evidence for CPR, nutritional drop. Here on the right on the screen, you find a PDF document from Alzheimer's Society. It's a free document. The patient could fill information in it when the patient on mild cognitive stage, which type of music does he like, what does he or she like or doesn't. So it will help us when it will come to advanced and severe dementia. So we know this person, how could we, what's the interesting item does he like or she like. So communication need to be a practical issue. When it comes to palliative care and dementia, there is no many medication that will help us. The communication in the early stage will help us. Communication, also interesting study. First one about CPR. It's around 200 patients. They have been interviewed in geriatric clinic, and they asked them, "What do you think? Would you like to have CPR or not?" At the beginning, 40%, around 41, they said yes. Then they explained to them evidence base and what would be the survival rate after the CPR and these things. So the percentage decreased to 5% from 41, only with communication. Other interesting articles, it shows caregiver and patient who get information in early stage of the disease about the prognosis and the most common cause of death, they had less rate to be admitted to the hospital, less percentage to get nasogastric tube, and this kind of intervention. Symptom control and prevention, I would like to highlight, it's not only pain in the advanced dementia that we need to think about it. Constipation, pressure ulcer, itching, sleep problem, and anxiety, many issues. It's not only pain. And for symptom assessment, as you know, in advanced dementia, we will not get an optimal history from the patient. So we need to have in our facility or in home health care or in the hospital or in clinic, different assessment tools. Like for the mouth evaluation, RUAG, one of the most used assessment tool. For PPSD, neuropsychiatric inventory. For pain, pain scale. These scales, it's not important which number or what would be the result. The most important, how are we going to use it and document it, and it could help us to have a plan to set the plan of care of the patient. Symptom analysis, the exclusion method, especially in dementia. Let's say you receive a call from the family, like the patient is tired or something has been changed in the patient. You need to start with the basic thing: food, elimination, mouth hygiene, how is the situation in the mouth, any history of fall, pressure ulcer, any changing of medication. By this way, we could have, we can set a plan here. Symptom prevention, patient on opioid or morphine. We know the patient will get constipation. I don't wait till the patient complain of constipation. I started early with the morphine. So I need to have a prevention method. Mouth evaluation routine on each visit every day. I advise the family to have mouth hygiene. Symptom relief when it comes to medication and other issue we started. Pain, we need one of the symptom the dementia could complain of. Nausea can be the only sign of pain, so we need to be careful of this one. So instead of treated the nausea, maybe we could give pain medication. We need to do a basic examination, physical examination. Suddenly alert behavior such as sudden worry could be a sign of pain. Clothes, maybe it's too tight, so the patient feels uncomfortable. Remember that dementia is also affected by other disease. This is EpiPain scale. Let's say a change in body language, behavior change. So here it's most important to document it, use it on daily base, weekly base. So if the first visit for you and the patient, maybe it will not help you, but if they start to use it before as a regular base, it will help. Other question, I would like to share it with you about the feeding and nutritional assessment with the for the patient. Do you see the question and the answer?
Yes, doctor.
Yes. I think, Eric, it's the previous question.
Okay, let me launch the other question.
Yeah, this question too.
Sorry, Dr. Ali, I'm interrupting you. We have 5 minutes left.
Oh, yeah.
Yeah.
Okay. I'll run. Okay. Here, I would like to highlight best feeding solution in case of decreased oral intake in advanced dementia is none of the above. Why? I'll come to it by my next slide. Nutritional issue in advanced dementia is common for many reasons. Apraxia, so disability in skill and action. Reversible cause, a high dose of sedation medication will decrease the, will have a side effect of decreased food intake. A study from Sweden have been done for around 280 patients. 140 they get IV fluid, 140 they didn't. So they showed people who get the 250 ml, they had more dyspnea on the last 24 days and also on the last 7 days before they dying. So 250 ml will worsen the dyspnea for patient. So what will be the solution? The solution would be the which is called comfort feeding or hand feeding, involved giving patient frequent small amount of food, sips of liquid, and explain to the patient. It's really important that tube feeding will not help the patient, and there is many risks with it. Dehydration, it's other problem, non-specific symptom in advanced dementia. A dry mouth, and how could we treat dehydration in advanced dementia? By oral cleaning with swab every 2 hours. It will improve the symptom. Question 3, I'll just skip it. What about last phase of dementia about this medication, statin? No evidence base to continue statin in this stage. Antibiotic, it could help us in symptom relief when it comes to per-oral antibiotic as dysuria and UTI, but IV antibiotic, it's different. DM medication, diabetes, it's reasonable to follow up the fasting and before bed glucose level, not hemoglobin A1C. Around 100 to 180 fasting, it's acceptable in this stage to have in blood glucose level. Antihypertensive drug, to have systolic blood pressure below 160 is acceptable. Osteoporosis prophylaxis, vitamin D and C, it's not no any evidence to continue to use it. Allopurinol, one of the osteoporosis treatment, should be discontinued if the patient cannot sit for 30 minutes. What about dementia medication, donepezil, memantine? Actually, there is different reference. One of them, if the mini mental test below 10, no need to continue the treatment. For memantine, you could continue to use it, but on the advanced stage, it's not wrong to stop the medication. And one of the way that you decrease it for 4 weeks, if no any change, nothing has been changed, so you can discontinue the medication and stop it, unless if you notice any anxiety or these symptoms, so you restart this medication. Pharmacological symptom that relief at the end of the life last a few days for the patient. We should not be afraid to give medication. We should not be afraid to give morphine. No one needs to die in a pain or stress. So, and the most appropriate way, it's subcutaneous, not intramuscular, as the patient not eating well, they will be thin. So the best method to give them is subcutaneous. These medication are not good, all of them need to be provided in the last few days for the patient. Thank you very much. And I'll take the question at the end. Thank you for this chance and for your invitation. Thank you very much. I hope I finished on the time.
Yes, Dr. Ali, you finished on time. It was really interesting topics with the several learning points. So a question, inshallah, will be done, inshallah, after the fourth session as the question answer panel, inshallah. So we'll move to the second session with Dr. Abdulaziz Al-Adhiani. I hope I pronounce Abdulaziz your name correctly. Dr. Abdulaziz is a professor on the College of Medicine in King Saud University Medical City in Saudi Arabia. He's a consultant family physician and geriatrician. He is program director of family medicine residency training program at King Saud University in Riyadh, and program director of the home health care program at King Saud University and Medical City. Also, he's the one of the founding members of the Saudi Geriatric Society. Dr. Abdulaziz is going to talk about elderly patient at your office, a case-based approach for family physicians. Go ahead, Dr. Abdulaziz.
Assalamu alaikum wa rahmatullah. Good evening, everybody. Thank you, Dr. Abdullah, for the invitation. Thank you, everyone who's attending the webinar, and thank you for the great preparation, and my honor to meet with you all, and hopefully, inshallah, we'll finish on time. And just remind me, Dr. Abdullah, once I pass by the time, and hopefully, inshallah, we can share some of the cases that we have seen in the clinic, and later on we will take your question and experience on these cases. Do you see my presentation now? Is it clear?
Yes.
Okay, great.
Yes.
So let's start with the first case. Just want to make sure that everything is okay. Sorry. Let's start with the first case. Just imagine that you have a lady, 77 years old, comes to your clinic with lightheadedness for 6 months. This episode mainly happens after lunch and dinner, after eating meals. And she doesn't have another symptoms like chest pain, palpitation, headache, or abnormal movements or seizure-like activities. And when you measure her blood pressure after the episode or during the episode, you'll find her blood pressure is 92/60. And while her usual blood pressure is 122/90. So she's diabetic type 2 on treatment in metformin, and she's osteoporotic on alendronate, and she's taking also calcium and vitamin D. Her respiratory rate within the normal and both position, but you measure her blood pressure while she's in supine position, and you'll find it 122/90. While she's upright, you'll find her blood pressure 116 and 116 and over 88, and she doesn't have any cardiac finding. So what we can do for this lady to improve her symptom? So if you think about this lady, you'll find that she has a change, a big change or dramatic change in blood pressure, especially after meals. While she's okay without meals, she's fine, and her cardiac problems, her vital sign, and an examination within the normal. So what comes to your mind usually? This is related to meal. This is what we call this is what we call postprandial hypotension. What's the difference between postprandial hypotension and postural hypotension? Postural hypotension can happen after changing position. While sitting down, standing up, she has postural hypotension. It can be caused by different causes, but postprandial mainly happens after meals, and usually defined as a change in systolic blood pressure more than 20 within 90 minutes, within 1.5 hours after meals. This is what we call postprandial hypertension. Usually a little bit common in elderly people, and reaching up to 35%. And very commonly people with autonomic dysfunction or long-standing diabetes, what can cause the neurological problems. This is worsen the condition. And also if the patient is taking antihypertensive medication, or she's restricted on salt intake or water, also it might have worsened condition. So patient might present with syncope, lightheadedness, like in our case, dizziness, falls, angina, cardiac manifestation. So what we can do for this lady, usually we trying to adjust her medication, try to make sure that she doesn't taking medication that cause postural hypotension, that's worsen the postprandial hypotension. Increasing water intake during meals. This will increase the extracellular fluid and increase her blood pressure. Try to control diabetes, long-standing diabetes. So she has also autonomic dysfunction. Try treating dysfunction. That's also this is the main thing. We usually divide her meals to very small meals instead of taking large meals, and this is cause pooling of blood into this gastrointestinal system, and this cause postural hypotension or postprandial hypotension. Also, try to minimize the carbohydrates. Carbohydrates increase the digestion, increase the energy intake, and increase the metabolism. So try to minimize the carbohydrate meals. Sometimes in rare cases, we advise patients, to encourage patients to wear a customized compression stocking to increase their venous return. This is mainly improve the postural hypotension rather than postprandial, but this can improve the condition. Try to teach patient and instruct patient not to stand very quickly after the meal, especially with patients who have recurrent attacks. And when she try to stand up, to let her take at least 30 seconds before walking. This is the first case. So just think about postprandial hypotension, which might be similar or a little bit different than postural hypotension. The other clinical case is just think about 67 years old man with a tremor. And this tremor started since 2 years, and mainly in the right hand. The tremor worsened when the patient drinks from glass, or when he tries to tie his shoes, or also to take things, or to write a paper. So this is mainly when the patients start to do things. He has hypertension, primary hypertension on treatment on ACE inhibitors, and he has also he's not a smoker or doesn't drink alcohol also. His father died from movement disorder, which he doesn't know what was the problem, and his mother died from breast cancer, and he's currently lives with his son and his wife. For when you do examination, his blood pressure within the normal, his vitals, respiratory rate, and heart rate are also normal. The main thing in examination, he looks comfortable, but you don't notice any tremor. While he's sitting down with no movement, there is no tremor. He's conscious, he's alert to the time and place in person, his power and tone for extremities are fine. The tremors, you notice that the tremor increase when he do the finger touch and finger nose touch. We usually do finger nose and touch to examine the dysmetria, or to examine the types of tremor. So when he reached the finger, he starts to have tremors. When he reaches his nose, also he starts to have tremor. Also, he has a little bit of head tremors, which is very fine. And there's no neurological symptoms. This is very important. Usually if you face similar case in your clinic, we usually do neurological examination. We usually do gait and try to find if there is any abnormal movements. This patient doesn't have other abnormal movements than the tremor, and he doesn't have ataxia, braxia, or he doesn't have also gait problems. He doesn't have rigidity or bradycardia. So and the gait is normal. So what could be the reason for his tremor? Always ask about family history. So his father died with movement disorder, which trigger things in your mind, and which what we call is essential tremor. Most likely this patient has essential tremor, and this is also a little bit common in elderly, and usually involves bilateral hands. Usually sometimes we find patient with the tremor in his headache or voice. But those patients doesn't have other neurological problems. They only have tremor in hands and voice or head. Usually familiar, 50% of the people, they have family history of similar illness. We don't know what's the problem exactly, but this is a little bit of one of the movement disorders that's common in this age group. Typically present with what we call action or postural tremor. Postural tremor, when you ask a patient to stretch his hand, postural, in the postural position, patients start to have tremor. Action tremor, when the patients start to move, this is action tremor. Action tremor or kinetic tremor, commonly with Parkinson's disease, but can be presented with essential tremor. Postural tremor is mainly with essential tremor. Resting tremor, while the patient is sitting down, now it doesn't move, this commonly patient with Parkinson's disease. So action tremor, postural tremor, and kinetic tremor. Movement disorder, a patient with resting tremor, Parkinson's disease. Postural tremor, commonly with essential tremor. Those were what we call the goal-directed, end of goal-directed movement, when the patient reach his things and moves or start to drink, start to knit, or start do things, the patient starts to have tremors. So how can you differentiate between those type of tremors? Essential tremor, usually postural, usually presence in bilateral in both hands, can be present in one hand, but mainly in both hands. Patient doesn't have neurological symptoms. There is no gait problem. There is no neurological deficit, no ataxia, no other things. And sometimes we find patient with head or voice tremor. Parkinson is a resting tremor, and usually patients would present with the typical symptoms of Parkinson, and can be also the presenting illness of Parkinson's disease. And usually a resting tremor or olfactory changes can be the initial presentation of Parkinson's disease. Think about the the classical symptoms of Parkinson, like rigidity, bradykinesia, or gait problems. Cerebral ataxia, usually kinetic when the patient moves, and patients usually have ataxia, dysmetria, and gait problems and falls. Physiological tremors, which is commonly with the adult people and younger people, especially with physiological changes like anxiety, hyperthyroidism, or patients taking stimulants or caffeine or different things, and usually present with those kind of conditions, but rarely patient at rest or patient when he's comfortable, rarely they have those kind of tremor. So how can you treat this patient? The first treatment for essential tremor is a propranolol or primidone, which is anticonvulsant medications. Propranolol is most effective one as a type of beta blocker. Sometimes we use atenolol in case of bronchial asthma patients. Usually we divided the dose into different, divided dose and multiple dose during the day. We usually give the patient 40 milligram TIDs. Or giving 100 of atenolol once daily. Propranolol and primidone are mostly and both equally effective, but the difference between both of them, propranolol mainly for limb tremor, and primidone is for limb tremor and voice tremor, but the headache usually poorly respond to both treatment. Sometimes we give both treatment as a synergistic medication. There is a rare interventions. Usually we send this patient to a neurologist, and sometimes they might use other convulsant medication, anticonvulsant medication like pregabalin, or using Botoxin or other Botox or other medications. Sometimes also brain stimulation intervention is part of the last treatment for this kind of condition. So those two cases, the clinical case, hopefully I'm on time. The third case is 72 years old lady with type 2 diabetes and metformin. She's taking a good dose of metformin, 1 gram PID, and she's also has primary hypertension in ARBs once daily, and she's complaining of unsteadiness, dizziness, and near falls for the last 1 year. She usually walks to the bathroom at night, and she's recently need to all the hallways to maintain her balance, and she's concerned about that it might become more and more, and she started to be forgetful than usual, and she denies drinking alcohol or having another symptoms. On neurological examination, she has neurological deficit, like both ankle reflexes are a little bit diminished, and brain sensation and vibration are also diminished on both feet, and she has also slight decrease in light touch. Other neurological examination, power and tone are fine, other reflexes are okay, and her lab shows that thyroid function TSH is 3.5. and vitamin B12 is 144 picograms per ml. So what's wrong with these patients? She's diabetic, she's hypertensive, and she starts to have forgetfulness, and she starts to feel dizzy, and she's feeling near fall, and she has a little bit of neurological deficit. Is it because of her diabetes? Is it because of her medication? Is it because of other condition? So and the lab shows low vitamin B12. Is it because of low vitamin B12? Let's see. So this patient has neurological symptoms, and borderline, we call it borderline vitamin B12 levels. And this is mainly suggestive for her vitamin B12 deficiency. So is it because of peripheral neuropathy caused by diabetes? Her hemoglobin A1C within the control, less than 7. And the hemoglobin A1C doesn't explain her forgetfulness. So it's unlikely to have a problem due to diabetes. So this is vitamin B12 deficiency, and a little bit common also in elderly in the community, reaching up to 20%. and in adult population might reach up to 50%. We usually, this is very important. Usually the classical symptom that we been taught in the medical school, we don't usually see it in patients, in usual patients, especially the low hemoglobin, anemia, and high MCV, microcytic anemia. So especially in patients with borderline vitamin B deficiency. And commonly those people present with neurological symptoms like paresthesia, numbness, sometimes weakness and instability, and sometimes cognitive impairment and memory problems. Those kind of patients are very critical, the borderline of vitamin B12 deficiency. And we usually make it as one of the first investigation to investigate patients with any cognitive impairment. Does metformin cause a problem? Yes, metformin reduces the vitamin B12 deficiency up to 30% by inhibiting the binding with intrinsic factors. Although the vitamin B12 can be absorbed through a dilutional process, but it is not that common. So mainly metformin causes problems, and the new guidelines of diabetes recommend considering screening patients with vitamin B12 deficiency, especially in patients taking metformin for a long time, up to 3 to 5 years. And they emphasize on those patients presenting with numbness or neurological manifestation. Keep in mind that vitamin B12 metabolism are used as a cofactor in metabolism of methionine, which is very important in neural function. That's why mainly done through folic acid. So folic acid usually uses the vitamin B12 as a cofactor. Folic acid uses the vitamin B12 as a cofactor for DNA synthesis and neural function. And methionine is very important for a neural function and also for bone marrow hemopoiesis. So how can you interpret the patient lab results? If you have a vitamin B12 more than 300 picograms per ml, that's mainly patient has a normal result and very unlikely to have vitamin B12 deficiency. And this is almost 90% sensitive, and you didn't need to treat patients with vitamin B supplement. If you have patients less than 200 picograms per ml, this is most likely patient has vitamin B12 deficiency, and this is reaching up to 100%, and you have to treat the patient empirically without doing further investigation. If you have patient with borderline, like our case, like 200 to 300, this mainly you need to treat patient with, to confirm vitamin B12 deficiency, and the serum vitamin B12 might be it might not reflect the actual vitamin B12. That's why we need to do serum methylmalonic acid or homocysteine. If you do methylmalonic acid, because methylmalonic acid is more specific for vitamin B12 deficiency, and homocysteine is more specific for both of them and mainly for folic acid. So we usually don't do intrinsic factor, because intrinsic factor just to differentiate between anemias and just indicating the pernicious anemia, and it's a little bit more sensitive, up to 50% for pernicious anemia. Do we need
Abdulaziz,
yeah.
sorry to interrupt, 5 minutes left.
Oh, sorry. So I'll go quickly. So you didn't need to do further tests. Peripheral smear usually present with very advanced or severe anemia, so you can see the classical symptom of hypersegmented features. Reticulocyte, we didn't usually do it unless you treat patient with vitamin B12 deficiency, and you need to make sure that the patient is responding to bone marrow, responding to vitamin B supplements. We didn't do intrinsic factor unless you want to confirm pernicious anemia. What we can do for these patients, we need to exclude the risk factors. We need to give the patient treatment either oral or intravenous, or parenteral. So parenteral is more reliable, commonly used. But if you see the oral and parenteral one that are almost the same, sometimes the oral is more comfortable to the patient and almost they give the similar effect. So, and can be given in empty stomach. If you have severe anemia, a patient with anemia and pancytopenia, you need to give the patient with parenteral injection for 2 weeks daily, and then weekly for 4 weeks, and then you give patient also folic acid, and patient need maintenance every month. If you have mild symptoms, oral medication is enough for the patients. You give it for 8 weeks. If the patient doesn't respond for 8 weeks, you switch to parenteral injection. So we usually do, after 2 weeks, we do reticulocyte to see the response to treatment. Do you need to screen patient? We screen usually patients who are taking chronic medication like metformin, PPIs, or anticonvulsant, or patient malnutrition, or on diet, vegan patient, or restrict vegetarian, or patient with GI disease or post-gastric surgery, or patient with neurological symptoms or cognitive impairment. This is maybe the last question or last case. We have another case, but because of time, so let's finish with this case. We have 75 years old woman, diabetes. She has painless visual loss, and she said, this is like a curtain going over my eyes, and this has been for the last 2 to 3 weeks. What could be the explanation for this patient or for the symptoms? This is what we call it amaurosis vogus. Amaurosis vogus. This patient is diabetic and she has painless visual loss, and this is recurrent episode, very short period, and this is like a curtain. This is more specific, describing the condition. This amaurosis vogus is characterized by painless rapid transit, less than 10 minutes, monocular painless visual loss. And this is a little bit common in elderly also. It's up to 24%. This is emboli. It's not ischemic. This is embolic retinal ischemia or retinal loss. This is the etiology because of a retinal artery ischemia due to atherosclerotic emboli coming from carotid artery. This is increase the risk for TIAs, increased risk for stroke also, and this is because of atheroma on carotid artery. If you have complete obstruction, this is increase the episodes of recurrent episodes of amaurosis vogus, which call it black emboli. You can differentiate it between other retinal visual loss, like painful visual loss, patient with macular degenerations, painless visual loss, which is gradually common, is not reversible, or optic neuritis, which is painful. The patient has symptoms, and usually in younger patients. So do you need to investigate? Usually there's no specific implications. The main thing you will need to do is carotid artery Doppler ultrasound to confirm the stenosis. And sometimes we do lipid profile to make sure that the patient doesn't have dyslipidemia or untreated dyslipidemia. If the patient had neurological symptoms, you might do brain MRI or CT. How can you treat these patients? You usually start antiplatelet medication, refer patient to neurosurgery or vascular surgeon to do carotid endarterectomy, especially in patient with recurrent case. Thank you so much. We'll stop in this case.
Thank you, Dr. Abdulaziz. Really, it was like interesting cases. I'm sorry, I have to cut you down, and we'll not go over the fifth case, but really interesting, informative 4 cases. We'll leave the question answered at the end. Now I will move to, thank you, Dr. Abdulaziz. I'll move to the next speaker, Dr. Salwa Suwaidi. She's the consultant geriatrician in United Arab Emirates in Dubai. Dr. Salwa Suwaidi, she is currently the director of the Center of Excellence for Senior Citizen in Dubai. This center with a lot of awards and good work. Dr. Salwa Suwaidi, as you know, is the first UAE geriatrician in United Arab Emirates, and Dr. Salwa is involved in several local initiatives and involved in putting a lot of guidelines related to elderly. Dr. Salwa will talk today about depression among seniors. Go ahead, Dr. Salwa.
Assalamu alaikum. It's a pleasure to be invited to this to the 4th Geriatric Conference of Abu Dhabi. I'm going to talk about depression among. Okay, I'm going to define depression and then talk about depression among seniors. How common is the problem? Is it common or not? What are the risk factors? What are the clinical presentation in elderly? How can we make the diagnosis, the effect on cognitive function, the effect of COVID-19 if we have time, and then management. Okay, so when we talk about depression, depression, as we know, is a common mental disorder affecting more than 264 million people worldwide. Here we're talking about all age groups. It's characterized by persistent sadness and lack of interest or a pleasure in a previously rewarding or enjoyable activity. I mean, suddenly something had changed. It can also disturb sleep and appetite, cause tiredness and poor concentration. The symptoms must last for at least 2 weeks and must represent a change in a previous level of functioning. So a patient usually is living a normal life and then suddenly he starts having all of these symptoms, and this would last for at least 2 weeks and it's affecting his or her life. Depression among seniors. Depression is more than just feeling sad or blue. It's a common and serious medical disorder that requires treatment among elderly. Depression is common among elderly, but however, it's not a normal part of aging, and I'm gonna emphasize on this point several times during my presentation. It's not at all a normal part of aging. The good news is that the majority of elderly are not depressed. However, it's common among elderly, but most of the elderly are not depressed. Some estimate of major depression in older people living in the community range from around 1 to 5%, and this would rise to around 13% in those who are requiring home health care and 11.5% in those patients in the hospital. So how is depression different for older adults? Definitely it's different because of many factors. First of all, older adults are at increased risk because almost 80% of older people have at least one chronic health condition, 50% have 2 or more. We know this. Most of our patients are hypertensive, diabetic. They have a lot of other health-related issues. Depression is more common in people who have other illnesses, for example, heart disease or cancer, or those with functional limitations, those who cannot walk, those who had a stroke, for example, and this is limiting their previously normal level of function. Number 2, older adults are often misdiagnosed and undertreated. This is very common, and this is significant actually, because healthcare providers might mistake an older adult's symptoms of depression as just a normal reaction to illness or to the life changes that may occur as we age. So accordingly, they would not realize the need to treat depression. They might consider this as normal reaction to their illness or normal part of aging. And then on the other hand, the older adults themselves often share this belief and do not seek help because they don't understand that they can feel better with appropriate treatment. I remember seeing patients who had a stroke and they wouldn't be very active with physiotherapy because they believe that it's normal for them to have a stroke, to be bedridden. I mean, simply because they're aging, which is the wrong idea. So how common is the problem? Clinical depression among elderly is common. It does not mean it's normal. It's not normal part of aging. Late life depression affect around 6 million American age 65 and older. Only 10% receive treatment for depression. And here we can see that it's really underdiagnosed and undertreated. According to the CDC, depression affect about 1 to 5% of the general elderly population in the community. Major depression accounts for 7% of the general elderly population and accounts for around 1.6% of the disability among elderly patients. So speaking about the risk factors, I mean, here I'm going to talk about risk factors in general. I mean, not only for elderly. Biochemistry risk factor, I mean, there are differences in certain chemicals in the brain that contribute to the symptoms of depression, mainly serotonin and other neurotransmitters. Genetic factor, depression can run in certain families. For example, some identical twins might have a 70% chance of having the illness in their other twin. Personality, we know that people with low self-esteem, those who are easily overwhelmed by stress, or those who have generally pessimistic view might be more prone to have depression. And then environmental factor, continuous exposure to violence, neglect, abuse, and poverty might make people more vulnerable to depression. And then when we come to elderly, there are 5 risk factors for depression among elderly community subjects, including bereavement, which is very common, sleep disturbance, insomnia, disability, for example, after stroke, prior depression, and female gender. And as we know, it's mainly the interaction between the biological factor, psychological factor, and social factor. Here we're talking about, for example, here we can see some of the risk factors and some of the protective factors. So for example, in younger age, we have the genetic factor, stressful life, neurotransmitter, previous depression as risk factors. Here, as we age older, we can see anxiety and disorder, cardiovascular, insomnia, stressful life event, activity, reduced activity, cognitive impairment. All of these are more risk factors that increase as we age. The protective factors could be the presence, the high education among young people, socioeconomic advantage among older people, close social network, which is very important, meaningful life, is very important. That's why we always say having the elderly with their family and having a meaning life is a protective factor against depression. So predisposing risk factor, again, among elderly, as we said, female sex, widowed or divorced status, previous depression, vascular brain changes, major physical and chronic disabling illness. Here, maybe we're talking about patients with, for example, osteoarthritis who were mobile and now they are on a wheelchair, or patients who had a stroke, for example, polypharmacy, excessive alcohol abuse, social disadvantage and low social support, and caregiver responsibilities, like, for example, if the elderly themselves are taking care of a patient with dementia, and personality type. So this is regarding the predisposing risk factor, and then precipitating risk factor. If a patient is having these predisposing risk factors, what can happen to precipitate the onset of depression? As we said previously, recent bereavement, moving from home to another place, like, for example, moving to a nursing home, adverse life effect, loss, separation, financial crisis, chronic stress caused by declining health, family or marital problem, social isolation, and persisting sleep difficulties. It's one of the very significant factors causing depression. Clinical presentation in elderly is different. Usually, this is the general clinical presentation: sadness, feeling of worthlessness, irritability, fatigue, crying spells, apathy, restlessness, lack of concentration, withdrawal, sleep problems, and change in appetite, and thought of suicide, physical aches and pain. When we come to depression in elderly, we have 2 types of depression. Usually, as we know, depression could be a reactive depression, or it could be an endogenous depression. And reactive depression can be associated with restriction of social competence due to increasing multimorbidity, loneliness, social isolation, consequences of retirement, and loss of partner or a close relative. These could be causes of a reactive depression. When we talk about endogenous depression, then we are talking about elderly who are frequently having symptoms combined with somatic complaints, mainly psychomotor restlessness and agitation, maybe panic attacks, which I've seen several times among our elderly. It's important to say that over half of cases represent a first onset in later life, Patients with late-life depression are heterogeneous. They're totally different. One patient can present with somatic complaint, and another patient can present with cognitive impairment only. Some patients present with panic attacks. We've seen a lot of cases presenting with panic attacks only. Depressed older adults are less likely to endorse affective symptoms and more likely to display cognitive changes, somatic complaint, and loss of interest than are the younger adults. Okay, how can we make the diagnosis? Depression among elderly is difficult to diagnose, as we said earlier, because of factors such as late onset. A physician might not think about it, comorbid medical illness, dementia, and bereavement. According to the Manual of Mental Health, the 4th edition, there are 9 criteria for depression: depressed mood, sleep disturbance, lack of interest or pleasure, guilt and feeling of worthlessness, lack of energy, loss of concentration, anorexia or weight loss, psychomotor agitation or retardation, and finally suicidal ideation. If we have at least five of these criteria, then we can, 5 of these criteria lasting for at least 2 weeks, then we can make the diagnosis of depression. Moreover, we can use the Geriatric Depression Scale, which would screen for 7 characteristics of depression in the elderly to look for or ask about the somatic concern, lowered affect, cognitive impairment, feeling of discrimination, impaired motivation, lack of future orientation, and then lack of self-esteem. It's a screening that would give an answer of yes or no, and we give a score according to the answer of the patient of yes as 1. A score of 10 or more indicate depression. Here we have it. It's a 15. You can see the GDS is 15 questions. Answers are yes or no. 5 might suggest depression. 10 might indicate depression. Okay, how can, I kept on mentioning that depression among seniors might affect their cognitive function. Depression is primarily a mood disorder. It shouldn't, if we think about it as a mood disorder, it shouldn't affect the cognitive function. However, in elderly, it can also be viewed as a cognitive disorder. In community samples, the co-occurrence of depression and cognitive impairment doubles every 5 years after the age of 70. The clinical challenge of treating geriatric depression with cognitive impairment is determining the extent to which cognitive changes are caused by depression or by any underlying brain pathology. And this is difficult because patients might only present with cognitive impairment, not the classical depression. Coexisting cognitive impairment is common in persons with late-life depression and can involve multiple cognitive domains. This includes executive function, attention, and memory. These impairments, especially the memory impairment, were attributed to dysfunction in subcortical structural related to the mood regulation, such as the hippocampus, and this can explain why these patients are presenting with cognitive impairment and more than the mood issues. Depression may be both a risk factor and a manifestation of cognitive decline. And of course, depression is associated with increased long-time risk of dementia. Here is a brain scan, a PET scan that can compare the brain activity during period of depression. You can see this, the one on the left side with increase of blue and green colors among patients who are depressed. And you can compare it with patients who are not depressed. You can see reduced brain activity due to depression. I think this is a very common slide that we've seen several times, comparing or differentiating between depression and dementia. Dementia has insidious onset. Depression can have subacute onset. Dementia, the family cannot recognize it earlier. However, in depression, family can recognize it earlier. Dementia has a slow progression, and depression can have rapid progression. It's very important that here patient admits deficit, okay, patient can complain about it, and here patient denies or he or she is unaware of the deficit. And here it's very important, this is very practical. When we ask patient questions, he says, I don't know to the questions. A demented patient wouldn't answer, I don't know. Okay, here I'm going to talk very quickly about how COVID-19 had affected elderly actually. As the COVID-19 began to spread in early 2020, older adults experienced disproportionately greater adverse effect from the pandemic, including more severe complications and higher mortality. COVID-19 came as if it's attacking mainly elderly people, and this had actually affected their mood. As countries are affected by COVID-19, elderly population were requested to self-isolate for a very long period of time in UK and other places. And the rapid transmission of COVID-19, the outbreak, the higher mortality rate among seniors, self-isolation, social distances, and quarantine could exacerbate the risk of mental health problems among elderly. We've seen this actually among our patients during the very difficult period of time, say from March until June, here in Dubai, actually, among our patients. So due to seniors' debilitated physical quality, their feeble immune system, and the associated chronic underlying diseases, decreased psychological capability, most of the deaths in this crisis were among senior patients. And the impact of the pandemic on the physical and mental health of the senior is more obvious. We've seen this. Most of the time being isolated, not able to see their families, and having a lot of limitation. Okay, coming to the management, depression is not a natural part of aging. Again, I keep on saying this, it's not normal part of aging. People who are depressed have increased suffering, impaired functioning, and increased mortality. So we have to do something about it. Fortunately, antidepressants have been shown to effectively treat late life depression. But this message has to be spreaded among healthcare providers, families. We should go and tackle patients with depression and start treating them. So late life depression is a major mental health problem that challenges clinicians and will remain so as people are aging. We are facing more and more elderly people, and definitely we will face a lot of cases of depression. Late life depression contributes to adverse functional, social, and medical outcome and can interfere with the treatment of their medical problems, such as stroke. We know this. If a patient is depressed after his first stroke, he was totally independent, and then suddenly he's bedbound, he's not able to move. If he's, on top of this, if he's depressed, he wouldn't be, active in the process of rehabilitation. An effective approach to this treatable disorder includes recognizing the risk factor, detection, and assessment. So we should think about, patient having all of the, some or all of the risk factors for depression, detect these cases, and do a proper assessment and treatment. Both psychotherapy and pharmacotherapy are options for treatment. I'll talk about them quickly. Talking about psychotherapy, psychotherapy can be used either as a primary or an adjunct method of treatment, depending on the elderly patient and the presenting problem. Here, this can include several methods like cognitive behavioral therapy, CBT, reminiscence therapy, pet therapy, meditation, caregiver and family support. The use of psychotherapy is uncommon among elderly depressed people, despite its effective. Maybe it might not be available in all the countries, or people might not be aware about it, or sometimes even it's an insurance issue that does not cover psychotherapy sessions, but it can work. Pharmacotherapy, here we're talking about the efficacy of antidepressant in old age is well established by Cochrane review. A further Cochrane review in 2000, so the first one was 2001, another one in 2000.
5 minutes, Doctora, sorry to interrupt you.
Okay. found that while selective serotonin reuptake inhibitor, SSRI, and tricyclic antidepressant are equally effective, both of them, SSRI tends to be better tolerated among elderly with less side effects. However, older adults tend to take longer to show a response to treatment. We know this by now, that older adults they would respond to the treatment, but they would take longer time than younger people. Speaking about SSRI and SNRI, the most commonly prescribed antidepressant now, if you compare it to the tricyclic, they are considered, according to NICE guidelines. NICE recommend that SSRI such as citalopram and escitalopram should normally be given as first-line treatment for depression. But we have to be aware of the anticholinergic side effects, which might include postural hypotension and sedation, but it's less common than TCA. SSRI are associated with slightly increased risk of upper GI tract bleeding because of their effect on the platelets function. So NICE guideline recommend co-prescribing gastroprotective medication for high-risk individuals. Moreover, which is a common problem that we see, or a side effect, hyponatremia is a potentially serious adverse effect associated with SSRI or SNRI in the elderly. It has been reported several times. So a caution should be applied when we are giving patients antidepressant with diuretics. Moreover, risk factors for developing hyponatremia include increasing age, older people, female sex, and a previous hyponatremia. So we should always monitor urea and electrolyte for these patients and be aware of symptoms such as lethargy, muscle cramps, anorexia, and headache. For some patients, mild hyponatremia could be asymptomatic, so we don't need to do anything about it. Tricyclic antidepressants are they're not the first line of treatment due to their adverse effect in elderly. We know their side effect: postural hypotension, fall and fracture, cardiac conduction abnormalities, and then the anticholinergic side effect. If chosen as a second-line medication, then nortriptyline would be the best and with less anticholinergic side effect. ECG and postural blood pressure prior to tricyclic antidepressant and after increasing the dose should be done actually to make sure to reduce to be aware of their side effect. How to start treatment? Starting dose should be half that of prescribed the dose prescribed for younger adults. And we know in geriatric medicine, we should always start slow and go slow, increase the dose regularly as tolerated over an interval of 1 to 2 weeks. And then the length of treatment is difficult. While remission rates in older people are comparable to younger adults, they can improve from the treatment, relapse rate is more common in elderly. So relapse rate once we stop the medication. So the optimal length of treatment in elderly is uncertain. Sometimes we keep the patient for more than 2 years on medication. NICE guideline recommends continuing antidepressant treatment for at least 6 months following remission, which can take longer, as I said previously. And NICE recommends continuing treatment for at least 2 years in a case of relapse or a recurrent depressive disorder, or if there is a risk factor for relapse. Okay, then we've decided to stop the treatment. Is there a technique of stopping the treatment? Yes, of course, we have to taper the dose. It has to be reduced gradually over around 4 weeks or longer if withdrawal symptoms emerge. If we stop the medication suddenly, discontinuation symptoms or withdrawal symptoms might present like dizziness, nausea, paresthesia, and anxiety, diarrhea, flu-like symptoms, and headache. The onset of these symptoms is around 5 days of stopping the therapy. Occasionally, symptoms might occur suddenly, if we stop the medicine quickly. And occasionally, they can be severe, particularly if the drug was stopped suddenly, as I said. ECT is recommended as a first-line treatment for psychotic depression in elderly with a good recovery rate of around 80%. And a good response to treatment. It's considered as alternative treatment for severe depression, or if a patient is having suicidal ideas and we need an urgent and a quick response to treatment. It's a relatively safe and well tolerated, although might not be accepted among people and patients and the caregivers. I'm gonna skip this slide and go to the take-home message because of the time. Depression is less prevalent among older adults than younger, but it merits special attention because it can have serious negative consequences. Depression is a serious medical condition among seniors. It's not a normal part of aging at all, and shouldn't be considered as a normal part of aging or accepted. The presentation of depression differs in older adults compared to younger adults. Depression is both underdiagnosed and undertreated by healthcare providers when dealing with elderly. And finally, depression in late life is treatable even among older adults with dementia. And thank you very much.
Thank you, Dr. Salwa, for this interesting presentation and for this update on practical points regarding approaching elderly adults with presentation of depression. Now we'll move to the next session with Dr. Yahya Al-Takriti. He's a consultant psychiatry at the American Center for Psychiatry and Neurology in UAE. Dr. Yahya, he's complete his training in psychiatry in Oxford in UK, and he worked a consultant in old age in Leeds in United Kingdom. Then he moved to UAE 2010. He worked psychiatry since then. Dr. Yahya will talk today about late onset psychosis, diagnostic and therapeutic challenges. Go ahead, Dr. Yahya.
Thank you very much, Dr. Abdullah. Can you hear me all right?
Yes, please.
Thank you very much for this conference, and nice to be among a lot of geriatrician colleagues. Right, as you said, I'll be talking about late onset psychosis. So I'll try to see live presentations so I'm going to talk about these objectives here. Many common psychiatric disorders are prevalent in the elderly, are associated with psychotic symptoms, and the causes and the clinical manifestation can vary according to the underlying condition. Psychotic symptoms can be associated with disturbed and aggressive behavior, and this will lead to as you will see, to the carer's burden and sometimes to admission to institution. Psychotic symptoms includes delusion, hallucinations, frequently accompany the neurodegenerative disorders in the elderly, and also can be started in the youth or middle age and then carry on in the older life. As our other speakers talked about the stressors of the old life, so you'll have physical illness, the various disabilities, sensory impairment, increased dependency, bereavement, retirement, all that will make people more likely to have mental health problems. I'm going to share with you some of the real case scenarios, patients that I have seen in clinic over the years. And first one is a gentleman, age 84, has the diabetes and coronary heart disease, but they're all controlled. His daughter brought him to our clinic saying that he has been becoming suspicious and paranoid. He sees the neighbors entering his room at night, stealing his belongings. He started to leave his house to go to visit his mother. His mother died many years ago, and he had to be brought back from the street by somebody who knows him. When they tried to stop him from leaving, he started to hit them with the walking stick. Also, the family reported that he was getting increasingly forgetful and confused. Investigations all done, ECG, MRI scan showed some mild diffuse atrophy and some ischemic changes in the periventricular area. So if I was to ask you about the diagnosis, I'm sure you will all agree that this is the case of dementia of Alzheimer's type. So the psychotic symptoms are part of this presentation. We started him on antipsychotics and cholinesterase inhibitors, and he improved gradually on that. The second case is a 90 years old lady. She's hypertensive, but well maintained on medication and has good mobility and good cognitive functions. The daughter brought her to clinic saying that she is increasingly anxious, fearful, not eating well. She started to lose weight. She claimed that her food has been tasting different from before. The neighbors, she believed that the neighbors, they come into her kitchen at night, they poison her food, and therefore she stopped eating and drinking. The daughter also said that she is not sleeping well. She lies down in her bed, anxious, she's socially withdrawn, and she needed a lot of reassurance from her daughter. She wants her to sleep in her same bedroom and leave the lights on. Again, the investigations were all normal, even the mini-mental state examination and the brain scan normal for her age. So if I was to ask about what you think the diagnosis is, I'm sure they will agree that we're talking about major depressive disorder with psychotic symptoms. We started treating her on antidepressants and antipsychotics, and she also improved on follow-up. The third and the last case is a bit younger lady. She's 68, well-controlled diabetes. She was a teacher, a retired teacher. She was very active, very independent lady. Unfortunately, she had a fall and broke her hip. So she was operated on, and the orthopedic consultant was satisfied with the outcome. 2 days after her admission to hospital, they called our team saying, please come see this lady. She is muddled, disoriented, agitated, sees strangers outside the windows in her hospital room, hitting the stuff when they try to approach her and pulling out the IV line. I'm sure many of our geriatrician colleagues, they're familiar with cases like this. A surgeon wanted us to assess her and take over her care, possibly take her to our psychiatric ward because he thought that she is demented or psychotic. So clearly this was a case of acute confusion state, as you can gather. And management was not just medication. We started to work with the nursing staff to educate them about the what's the best thing to do, how to approach her, improve orientation, bring some picture and some like a clock and calendar, also reduce the stuff switching, etc. We treated her with some small dose of haloperidol and lorazepam, which was very helpful. You can also use risperidone or olanzapine, small dose of that. She came to clinic a couple of times after that, and she was fine. So what's psychosis? We're talking about that. It's a symptom or a condition that affects how the brain is processing information. It can be caused by mental or physical illness or trauma. Usually what happens is misinterpretation of reality, and you will start to have false fixed beliefs like delusions and also hallucinations. Often we have also disorganized speech and disturbed behavior. So as we said, can be part of any of these disorders. You can have acute onset psychotic symptoms like happens in delirium, like the case we discussed, in physical illness or drug induced, but you can have also chronic psychotic symptoms like the case of schizophrenia, late onset, for example, delusional disorder, affective disorders. You can have it as part of the neurodegenerative disorders in Alzheimer's or in Lewy body dementia, or in part of Parkinson's, or any chronic medical condition like brain tumor. Obviously, elderly are at higher risk, especially if they have visual impairment or any sensory impairment, females, socially isolated, ethnic minorities. They have dementia, for example, they will be more at risk, and any changes in the frontal or temporal regions polypharmacy like many of our patients are. So all that makes them more at higher risk of developing psychosis. How prevalent is difficult to say how prevalent psychosis in elderly, because it's difficult to estimate due to the lack of diagnostic consistency. Sometimes they say, for example, in community sample, it's up to 4.7%, in nursing home up to 63%. So it's difficult really to say how prevalent is the psychotic disorder. Let's talk a bit about Parkinson. I know many of you treat people with Parkinson's. Here they say that psychosis in Parkinson's can be between 20 to 60% of people who suffer from Parkinson's can have at some point psychotic symptoms often due to the anti-Parkinsonian drugs rather than to the neurodegenerative process. Hallucinations are quite common, more common than delusions, and usually the psychosis appears in the later stage of the illness of Parkinson's. Treatment used to treat psychosis, you can use antipsychotics, but here also they talk about some research showed that small dose of clozapine can be useful. Cholinesterase inhibitors also like rivastigmine, donepezil can be helpful. This is a recent review published about this topic, which shows that psychosis in Parkinson's can contribute to high mortality and morbidity. And usually what we do when we see some patient with psychosis, we try to reduce the dose of the dopaminergic agent in order to improve the symptoms, but often not enough. Therefore, you need always sometimes to use antipsychotic medication, as we said, clozapine or cholinesterase inhibitors. The interesting thing in this review that they talk about a product which is the pimavanserin. It's a serotonin 5-HT2A receptor inverse agonist, which is they found out that it's quite effective in treating the psychotic symptoms in patients with Parkinson's. We don't have this component here, but it's been approved by the FDA in America. Lewy body, also many of you have patients with that disorder. Lewy body, we know that visual hallucinations are very common in that. Sometimes other symptoms also are prominent, like Ian McKeith talked about it, that you have fluctuation of cognition, Parkinsonism, frequent falls, and sensitivity to neuroleptics. Usually when we give them small amount of dose of neuroleptic, you find that they will have Parkinsonian symptoms and makes it difficult to treat. Some evidence for patients with Lewy body that olanzapine and rivastigmine, small dose of them can be useful. This is a case report recently published about a Japanese patient who was diagnosed as Parkinson's at age 45. They treated him with pregolide, and at age 60 he started to have like delusions against his wife and started becoming very aggressive towards her. Unfortunately, at age 72, he died. So they were able to do autopsy for this gentleman, and they found prominent Lewy body pathology in the basal nucleus basalis of Minert. And this is like just to link to explain what happens, why we have a lot of visual hallucinations in this type of disorder. We know that dementia has a lot of neuropsychiatric the symptoms, hallucinations up to 50%, and delusions, but also we have paranoia, suspiciousness, aggressive behavior, and restlessness. You can have combination of those symptoms. So somebody could have depression, for example, plus hallucinations and suspiciousness. These authors, they talked about, I don't know if you can see my screen very well, it's very covered. about some kind of delusions like couple grass when they start feel that false belief that previous person who is well known to them is, for example, husband or housemaid has been replaced by imposter. Mirror image also, I'm sure many of you have seen patients with that when they look in the mirror and themselves, they misidentify that person. Often you see them, they're becoming very aggressive. They smash the mirror because they're scared of this patient. So these are some of the delusions that you might see in dementia. What about the treatment of psychotic symptoms in Alzheimer's dementia? Here they talk about evidence. For example, haloperidol can be used, small dose of it, up to 2 to 3 milligrams only a day. So quite small dose because they tried smaller of that, but wasn't effective. Risperidone, we use that as well in our work. You need to give small dose, 1 milligram, in order to control those symptoms. Olanzapine also useful. They tried 5 milligrams, which was significantly effective. The increase of the dose, if you give 10 to 20 to 15, wasn't any good. You just have a lot of side effects and metabolic syndrome. We like in our work, quetiapine, we use it quite a lot. Here, the authors, they talked about you can go up to 300, which is considerable dose really for patients with Alzheimer's, but to control psychotic symptoms, sometimes you need to increase the dose. Plus the cholinesterase inhibitors, as we said before, you can use them to control psychosis. This is an article, they showed the outcome as longitudinal study. They did choose over 400 patients and divided them in 4 groups, one which developed hallucinations, one only delusions, and the third group was both delusions, and the fourth group did not have any psychotic symptoms. They followed them up and they saw that they came up with the conclusion that when you have hallucinations and delusions in same patients, you have a greater severity of dementia, poorer cognition, and poorer outcome of dementia. So psychotic symptoms in dementia are considerable, and they can affect the outcome. And patients, as we said earlier, that might end up in a nursing home because you cannot control their behavior. This is an interesting study also, but they did like about first episode psychosis. They collected about 100 patients. This done in Finland, and they studied them first episode psychosis, and they went back to do MRI scan, CT scan, and to see if people who diagnosed with first episode psychosis have any changes in the brain as a brain pathology. In fact, they found that high frequency of cortical brain atrophy in all diagnostic groups of first episode psychosis. Delirium, we talked a little bit about delirium. People are more subject to delirium, elderly, obviously, cognitive impairment, sensory impairment, but people which have like a physical restraint or catheter, they will more be subject to delirium. Sorry if I'm going through them because I want to, we wasted a bit of time at the beginning. Schizophrenia, I'm not going to tell you all the symptoms which you know about, but we got diagnosed as late onset and early onset. Late onset after age of 45 and early onset before that. There are some similarities between them, but there are also some differences, as you can see in this slide. So the late onset has fewer negative symptoms, more sensory impairment and social isolation, more visual hallucinations, less formal thought disorder, less family history, and women more than men. So this is the late. Sometimes you read about very late onset schizophrenia. So schizophrenia, people did not have psychotic symptoms, and after the age of 60, they started developing schizophrenic symptoms. So they call it very late onset schizophrenia, like psychosis. Again, here you will find less family history, more sensory impairment, less negative symptoms. The interesting thing about this group of patients that they difficult to engage in the treatment. you treat them and you ask them to follow up, and they lose follow up because they don't see any improvement in their quality of life. They have something we call anosognosia, which is they have inability to perceive the reality of their own condition, which is very common in this group of patients. There is also the increased risk of side effects and mortality in this group. This is why they suggest that maybe think about some non-pharmacological interventions. That brings us to the treatment options of schizophrenia in the elderly. Other colleagues talked about the importance of family therapy and non-pharmacological therapies. Here also we highlight that. Dr. Bembo talked about how family intervention is important. We all work when we see our patients. Inevitably, we find ourselves involved with family. We get to know them, they get to know you as a clinician. You have to work with them. I worry a lot when I see one of my patients coming on their own to my clinic because I feel that I'm missing something. There is something missing in the background history. So you have to work with families all the time. Often the referrals are initiated by them, and or there is a reason for that, like they normally precipitated by family conflict, retirement, or bereavement. So you have to work with families. CBT also important. McCoy talked about combining CBT with social skills training to reduce the cognitive impairment and improve ability to cope with stress. Psychosocial therapy also important for similar reasons. What do we use in psychiatry? Pharmacological treatment also, we use it a lot. Despite that, not enough information available to guide us really. So if you read about all the antipsychotics, they mainly they guide you to treat younger adults, not in the elderly, most of them. We use atypical a lot, as you will see next slide, but also sometimes we use atypical antipsychotics, the older antipsychotics, because also some of them like Halodol and flupentixone, they come as injectable medication. When you start antipsychotic medication, always keep in mind.
Sorry, Dr. Yahya, 5 minutes left.
Okay, I'm nearly finished. Always keep in mind that your patients getting old will affect the efficacy and tolerability of the medication, will increase sensitivity. Always we deal with patients with comorbidity. Most of the time they are on loss of medication. So these are really complicates our work, and we need to keep it in mind. We need to keep it in mind because the distribution of the psychotropic medication in general, they are altered. So you will have like delayed gastric emptying, reduced level of plasma protein, decreased renal blood flow. They're all those things probably you know better than me about all those effects. So that will affect the distribution. Conventional antipsychotics, the older type, we call them conventional or typical. They are some of them high potency, so you need a smaller dose, but they cause more Parkinsonism. The other group is low potency, they cause more sedation. As I said, we are using them less and less, but still we might find some patients on this medication, especially in like poorer countries. Atypical, they work on the 5-HT2A receptors rather than D2 like the typical. It's common practice, we do it all the time. Most these sort of drugs are licensed for younger adults with schizophrenia, but we have to use them because there is need for that. As I said, risperidone, olanzapine, quetiapine, we use it. Aripiprazole is an interesting one because it works as agonist on the D2 receptor. So it's effective on the positive and negative symptoms and does not cause a lot of sedation. Clozapine, I'm sure you heard about it. Some people are worried about using it, but can be effective. The drawbacks is that you need to, it has side effects obviously, but also you need regular blood tests because it affects the white cell count. So some people get worried about using clozapine, but can be effective in the elderly. We talked about side effects. can worsen, all antipsychotics can worsen the cognitive functions. In 2004, I'm sure you read about this, the Committee on Safety of Medicine, they were worried about the excessive use of risperidone and olanzapine in patients to control behavioral disturbance in patients with dementia, and they said you shouldn't use it because it increased the risk of stroke. I think this is my last slide. They did a study to show if we give the olanzapine with sertraline or just olanzapine with placebo to two different groups for 12 weeks. And they found that the remission rate for the group which they took olanzapine and sertraline was better, 41% versus 23. Rate of remission similar for both, and both experience increase of cholesterol. However, the weight gain, we know that olanzapine is responsible for weight gain in most of our patients, but was so less in the other. So it's not all doom and gloom when you use your medication. Some references. Thank you very much. I hope I finished on time.
Thank you, Dr. Yahya. Really, it was amazing presentation with a lot of updates and practical points. Now we'll move to the question of answers, and I hope all the four speakers still there. If you can't hear me, Dr. Ali.
Yes. Hello.
So there's one question from one of the audience saying why there is a dysphagia in severe dementia.
It's a process of the disease. As you know, in dementia, we lose memory, one of cognitive function. Also, we lose something called apraxia. It's the disability in skill and action. So the patient, in easier way, the patient forget how to eat. There is other reversible causes. We need not to forget these causes. Antipsychotic, side effect of other medication, dehydration, mouth and hygiene and fungal infection could be the cause of this dysphagia. I have noticed other question. I don't know. Do I answer on them?
Well, I mean, okay. So go ahead.
I think it's Anita, Abbas, and Benz. They ask about the role of
rehabilitation.
As I show you in the first slide, palliative care for patients with dementia, it's not depend on the superman or the smart doctor alone. We need a team. Of course, there is an important role of rehabilitation, but with a different aim. We will focus mostly on the functional level instead of rehabilitation. So I'll maintain the function level of the patient as possible, and to be realistic in our rehabilitation program. Thank you.
So maybe the other way of they're asking the question, how the patient with advanced dementia will respond to rehabilitation, like because of their severe cognitive impairment, and how their rehabilitation will help to improve their, for example, they have like strength, mobility issues.
Balance, I think balance, and most of the training should be focused on the functional level, like transfer from bed to chair or walking with assistance. Focus on the balancing training, as you said. But to be realistic, it will not improve the functional level. It only will delay the decline. So this is the role to do.
Also for Dr. Abdulaziz, you see this question about customized stocking wearing schedule. There is any schedule for it?
Wearing customized stockings usually recommended those people who is standing or walking or the person on travel. So we usually use it during the day and remove it during the night, because we need to avoid the rebound hypotension or tolerance or hypotension tolerance. So we usually recommend it during the day, especially for those people who is walking. They can wear it the whole day.
And there is a question, I don't know who's going to answer it, but from the speaker, well weighted wrist cuff and adaptive weighted spoon device will help for feeding patient independently.
I think it could. Why not? Maybe especially when it's moderate to severe, maybe not severe dementia. Maybe at this stage, maybe it's not contraindication. As I said, we don't have any randomized clinical trial to say yes, it will work or not. As it is non-pharmacological way or methods, I think it's good to try it. Why not? And I don't know about other colleagues if they have another answer.
Okay. And for Dr. Abdulaziz, patient with vitamin B12 deficiency and falls, the role of rehabilitation.
Those people who or those people who have a vitamin B12 deficiency, we usually treat the cause. We are not focusing on physiotherapy unless the people have deconditioning or they have muscular dystrophy or atrophy or declining in function. So we can do rehabilitative programs to strengthen their muscle and maintaining their function or balance. So we usually focus in the main problem, which is vitamin B12 deficiency.
And Dr. Salwa, so safe combination of antidepressant and drugs and patient with dementia.
Sorry, I didn't get the question.
So I'm like,
Safe?
You see that we are as a geriatrician, we are like cautious using the medications. So when
Yes.
it's come to the one question is like the scenario that you use 2 antidepressants in elderly patients.
We prefer to start, as I said, we start low and we go slow. Usually, as I said, elderly patient would respond to treatment of depression. We can combine medication if we give the first medicine time for it to work and it's proven that it's not working. I prefer to stop it and to give another type rather than giving the patient 2 anti-dementia medication and predisposing this patient to more side effects. So for me, combining medication, I have never done it before. I prefer to stop one and to try another one.
Okay. And if the patient, like for example, one question I saw that the patient is like, he's diagnosed with depression and he denies I have depression and he rejects treatment. How are you going to deal with this patient?
Which is very common, especially for the patient female. I've seen it a lot with female with a lot of physical complaint. I mean, back pain, headache, and a lot of other symptoms that do not have a clear explanation. Actually, sometimes, unfortunately, we have to give the patient medication even without telling them. Unfortunately, we do it sometimes because we can work with the caregivers. I've seen a lot of caregivers who are actually suffering because of the multiple complaints, especially the panic attack. I mean, recently I've seen a lady who has, the family would call the ambulance several times because suddenly she would say that she cannot breathe, she's having a lot of issues, and they call the ambulance for her every time, and she's totally fine. All her vitals, her parameters are fine, and she would improve. I mean, for this lady, we started her on antidepressant. Unfortunately, we didn't tell her it's antidepressant because she would refuse it. We spoke to the family and the caregivers who are actually the ones giving her the medication, and she had improved. They said the rate of these panic attacks had reduced. So again, I mean, it's not easy. For some patients, we do explain to them and they would understand the importance of taking antidepressant, especially if we explain to them that this is not an addictive drug and you will improve by taking this medicine, and we will stop it after some time. Some patients, they do understand this and eventually they accept taking the medication.
And there's other question, Dr. Salwa, like, so example, there's question that patient with elderly having depression and for many reasons and really affecting their eating habits, and elderly intake may lead reduced, like we need to malnutrition. How we can help them to retain their satiety or their appetite?
Okay, I believe that not only for depressed patients, I mean, oral intake is reduced, among elderly, even those without depression, because of changes in their taste bud and their smell. I believe having the family sitting with the patient, joining them for meal would help them accept the food. Maybe we can have a lot of flavors for the food rather than salt. I mean, if we are reducing the salt, maybe we can have a lot of spices in order to change it. Multicolor food or a plate for the patient might be appetizing. And again, having smaller meals shared by the family can usually help. And sometimes if these patients are not able to eat or they're really refusing, maybe a flavored supplement, like for example, Ensure and other supplements might help.
Dr. Yahya, there's a question regarding the, here, just 1 second, please. Okay. So regarding about stem cell therapy and schizophrenia.
Right.
Hmm.
Yeah. I'm not aware actually of any development in this field.
And there's other question, reason for memory image in Alzheimer's disease. It is a level of cortical level or local problems in the eye?
Yeah, I think it's due to the cortical impairment. And it's the same as when they cannot recognize any family member, really. So the mirror image the delusions is they see themselves well, but they don't recognize that this is them. They think it's an intruder. This is why they're scared. And often we say to the family, remove mirror or cover them because they get scared.
And I don't know whether you have an idea about, is tinnitus is also present in Alzheimer?
I'm not aware of tinnitus being a big problem, really, or a symptom of Alzheimer's.
Okay. So there is a question for you. There is any difference in the outcome? This question here. Outcome of the use of combined kinase inhibitors than prescribing one of them, and outcome of dementia, like using one or use combination, what's better?
With the cholinesterase inhibitors, often, yeah, it's a good question, because we often, once we see that one is not, we don't start with two, as you know, straight away. We wait to see if one of the medication is not enough or the patient continue to deteriorate in their cognitive function, we introduce another one. But to start with, we often start with one.
So I mean, the question is like, for example, usually when you combine one of cholinesterase inhibitor and using an NMDA receptor antagonist, this memantine. This is the combination, but we are not combining two cholinesterase inhibitors.
Sometimes we do that. For example, sometimes we do patches, Exelon patches with Aricept. We do sometimes combine two AC inhibitors. Yes.
Okay. Any evidence, doctor, from the guidelines or any study using both using two cholinesterase inhibitors?
I think there are some studies to show that it can be better outcome and slow down the deterioration. Yes, I think there is some.
Okay. And there's question, is dementia a genetic disease?
There is a strong family component in dementia, especially in early onset dementia, the one which starts before age of 65. You will find that there is a strong family history. So that's the genetic component. Obviously, for the other type of dementia, you might have more chance to develop dementia if one of your parents have. But the strongest, and there is evidence that the early onset dementia has a stronger genetic component.
Okay. For Dr. Abdulaziz, do we need to take vitamin B along with metformin if the patient is long-term treatment of metformin? Like even if the patient doesn't have vitamin B12 deficiency, because he's taking longer time, for long time metformin as prophylaxis, just take it as along with metformin.
Yeah, this is a common practice, and I don't aware of any evidence that a supplement of vitamin B12 is a good practice to give it to the patient who's taking metformin. We know that the metformin on the long run might cause vitamin B12 deficiency, but we usually don't supplement patients with extra vitamin B12. And we've seen patients who's taking vitamin B12 and metformin, and they have very high level of vitamin B12. And you know, high level of vitamin B12 can do the opposite effect of low vitamin, low opposite the effect of vitamin B12, sufficient vitamin B12, and can cause nerve damage. So if you think that the patient might have deficiency, do screening. If you think that the patient is in high dose for a long time and the patient has cognitive impairment, or patient with neurological deficit or symptoms, or patient has a history of falls, or patient has signs of anemia or paresthesia or dizziness, do screening. If you find it with borderline or vitamin B12 deficiency, you might go for treatment.
Dr. Salwa, there is any certain statistics of incidence and prevalence of depression in UAE?
I'm not quite sure because actually we don't have a health registry yet in the country. We've been talking about this last week, and I don't have a clear numbers or figures. But talking about our clinic, we see a lot of like, for example, maybe 2 out of 10 would be depressed. Yes.
Okay. Dr. Yahya, reverse sleep pattern is frequent complaint encountered from dementia caregiver. What is your advice in handling this
I
problem?
did not hear the question.
Sorry?
Well, can you repeat? Yes.
Is it, reverse sleep wake cycle is frequent in patient with dementia. So one advice.
Yes, it is a big problem. I mean, we work always with families about that, because the patient is awake at night, and the whole family obviously they need to sleep because they're tired. Often before starting medication, we work a lot on sleep hygiene with the family, obviously, because the patient will not comprehend all what we say. So avoid long periods of sleep during the day, make them walk, make them move a little bit if possible, avoid giving them stimulants late in the evening, avoid giving lots of fluid. Sometimes we do use a small dose of sleeping tablets or sedative antipsychotics, but often sleep hygiene really we work on first option.
I guess we are reaching to the end of the question and answer panel. I want to thank all the speakers for joining us today with a lot of this update and practical points we get today. And I hope the audience are enjoying so far our scientific event. So now we'll take a break, and we'll restart the second session at 7:30 Abu Dhabi local time. We left with 3 sessions. So thank you again, and we'll see you soon.
Thank you very much.
Thank you.
Thank you, Dr. Abdullah. Thank you, everyone.
Thank you, doctors. Thank you. Appreciate it. Thank you. Okay. Hello again, my dear audience, my dear colleagues. So we're going to start the second session. Can you hear me? So I want to give me great pleasure to introduce the next speaker, Dr. Abdulrazak Abyad.